There must be an issue with audio.
In our health hours, the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning and welcome to our health hour. Thanks for joining us. It's a wet, rainy day in Manchester. I don't know what it's like for the rest of you, but it's nice for those of you that have joined us. So my name's Ngozi Ediasage. I'm a paediatrician specialising in newborn babies, and I work in Manchester. And I'm delighted to welcome back an old friend, Dr. Margaret Ikpoh. So those of you that have joined us more than once will recognize, hopefully recognize Margaret's name. She's done various topics with us before, and she's an excellent speaker. So I'm really pleased that she's here today. But she's got a really important topic today because we have these health hours for your well-being, but well-being is for all aspects of our lives. And one of the things that she's going to talk to us today about is about contraception and sexual health. It's an area that sometimes can cause a bit of embarrassment, that sometimes is not addressed as well as it should be. So please pop your questions in the chat. As usual, we'll have an opportunity to ask questions. And if you feel slightly embarrassed about some of the questions, you can send them privately to me and I'll ask on your behalf. But I'm delighted to welcome Margaret for what I know will be an interesting and hopefully interactive session. Thank you.
Thank you very much, Ngozi. I hope you can hear me okay.
Yes, I can.
That's great. So I'm just going to start by sharing my screen. Let's go from the beginning. Right, so I hope you can see that. So thank you for having me back. It's been a while, I think, but it's good to have a break sometimes. And I really just want to shout out to all of you for keeping this session going and keeping everyone informed. So my name's Margaret. I'm a GP and I'm currently based in the Far East, otherwise known as Hull. And I also, I do wear quite a few hats. I'll just quickly put my roles there. But the other main hat I have is I'm one of the vice chairs for the Royal College of GPs. So I look after the exam conference and I help to shape what GPs need to learn to make sure they provide the best care for their communities. So I've got quite a lot to talk about. I'll try and see if I can keep my eye on the chat at the same time, although I admit I sometimes find it difficult. So please, Natasha, do shout out if there's anything pertinent that comes up. Otherwise, I think I've got 45 minutes to do this and then we've got a good Q&A afterwards anyway. So Ngozi's already mentioned the importance of sexual health and well-being. Just to let you know, if anyone's watching this and is, how do I say this? So there are some terminologies I may use to describe parts of the human anatomy. And I'm just conscious if you've got maybe young children in the background or people that you don't want to listen, I'll just put that warning out there now. But the World Health Organization defines sexual health as not just well-being, and it's not just the absence of having any disease. It involves respect, it involves safety, and actually freedom from any form of discrimination and violence. So I'll start off with contraception first. What is contraception? The actual definition is any deliberate use of artificial methods to prevent pregnancy as a consequence of sexual intercourse. And what I'm going to try and do throughout the course of this next 40 minutes is just to empower you with certain tools that you can use when you go and see a healthcare provider, whether it's your GP in a general practice or if you go to a sexual health clinic. I'm conscious now that a lot of our patients that I see are already informed by another source somewhere, whether it's by talking to a relative or a friend, or whether it's something on the internet. I think that's something that we need to get used to. So don't be shy when you come and just say, because just say, like, I've seen this or I've read this, and what are your thoughts about it? You would not and you should not be judged. And anything you're offered, you don't have to make a decision there and then on that day. Some people do feel that they say to me, I felt a bit pressured that I had to choose right in that consultation room. Well, you don't. You can always go away and think about it and try and understand whether whatever you're offered fits into your own lifestyle. If you work night shifts or your pattern is quite erratic, maybe taking a tablet every day might not be the best form of treatment for you. So very quick anatomy stop is just describing the female anatomy in terms of what it means. So in the normal female anatomy, you know that we each have 2 ovaries, and the body, I don't know if you can see a pointer, I don't have a pointer, the body of the womb is called the uterus. And every month, if you have a regular cycle, your ovary will release an egg which travels down the fallopian tube, which is the passageway to get into the main body of your uterus. And as long as the conditions in your womb are favourable, so the lining's built up and ready to receive or meet the sperm, then one would hope that pregnancy will happen. So that's the upshot of it. The menstrual cycle, again, this is based just on the 28-day cycle here. You have 2 phases, essentially. You have the phase where you have the ovary that releases the egg, and it's called a follicle, and it starts to grow. And that's what tends to happen. And mid-cycle, you can see right at the bottom here, that's the lining of your womb, which we call the endometrium. And what tends to happen is the endometrium starts to build up, ready, basically, its sole purpose is ready to receive a fertilized egg. And that tends to happen. And if that doesn't happen, so if there's no fertilized egg that embeds itself in the lining, then the last part of that cycle, it will shed. And that's when you get your menstrual bleed. So that's that. There's 2 types of contraception, generally speaking. So I've divided them into the hormonal types of contraception and the non-hormonal types. There are so many different types of contraception now. Even, as a general practitioner, there's always something new that I'm not even aware of. The key is, again, just to have a discussion. Don't have to make a decision, and just work out what works well for you. Commonly in the UK, the most common types are the tablet forms or the implant, or I'm not allowed to say coil because I got told off for saying coil by my family planning partner the other day, but what we call the intrauterine devices. The ring is not as popular in the UK as it is in the European continent. And I think there was a study done a few years ago, and I think the reason for that is they found that British women weren't keen really on just fiddling with themselves basically every week or whatever it took to replace the ring. We much preferred a hands-off method. Right, so I'm just going to quickly, give me 10 seconds because something's obscuring my looking at the slides. Okay, so what tends to happen? Generally, what hormonal methods do is they stop the egg, the fertilized egg, from embedding itself in that lining I described earlier. And they do that in a variety of ways. They can either prevent ovulation, so they stop the ovary from even releasing egg in the first place. They make the endometrial, the lining, thinner, than it should. And actually what they tend to do around the bottom of the uterus, which we call your cervix, they thicken the mucus. So that acts as a barrier, and actually any sperm that's in that area will find it difficult to get through. As long as it's taken correctly, hormonal contraception tends to be very, very, very effective, over 99% effective. But it is very user dependent. So generally you have to make sure you take it every day. And it can be affected by quite a few other things. So you need to make sure that your medication list that you're on, if you are on any medication, is reviewed by your GP to make sure there's no particular interactions. You need to make sure that if you're buying anything over the counter now, there are some herbal medicines. So for example, there's a common one called St. John's wort, which some people take for depression. That can actually affect your contraception as well. If you are sick, so if you have any vomiting or diarrhea, then obviously the contraception doesn't stay in your body for as long as it should do. So there are guidelines that you need to adhere to. Again, it will all be explained by whoever's prescribing it to you, what to do if you're sick, or in fact, if you forget, because we are all human, if you forget to actually take your pill. Okay. But actually, one of the best forms of contraception we know are the intrauterine devices. So those are the devices that are placed inside your womb, because really you don't have to think about taking anything. It's already there. If you're sick, it doesn't matter. It's already there. So it's not reliant on us having to remember what to take. So those are it is the most effective one, but there are others which I will come to in a minute. So now, so the implant. Now, the implant, from my experience, tends to be more common with the younger generation for reasons which I can understand. They don't want to remember taking a pill because it's difficult, particularly if you are going to uni or college or you're starting a new job. It's there for 3 years, and it's a very small rod that's placed just in the arm in that site. It's a very low dose of what we call progestogen only, and sometimes it can help with painful periods, especially if you've got heavy bleeding. There is a small minority, however, of women that might come back and say, well, do you know what? I'm having lots of irregular bleeding on this. So that can happen. But there are things that we can do to counteract that. Sometimes it might mean that we might have to give an additional tablet just till that bleeding settles. If you know that you're the sort of person that will be fiddling with it, because one of the reasons why some people don't want the implant is the fact that they've got a foreign body in their body, if that makes any sense. So if you know you're the sort of person that's going to constantly be fiddling with it, then it's probably not the best thing for you to have. So again, it's just having that discussion with your healthcare provider with regards to what you think is best for you. Again, the most common type of contraception we use is something called the combined pill, which is made up of artificial hormones in different strengths. But most pills will have they will have estrogen and a progestogen component. And the main advantage of the combined pill, in my experience, is women come back and their periods are lighter, they're less painful. In some cases, people's skin looks better. And it is, if taken, again, correctly, a really, really good pill to take. Historically, I'm still finding a lot of women on the old way we used to prescribe it. So we used to prescribe the pill to mimic the menstrual cycle I talked about earlier. So traditionally, a woman would take the pill for 3 weeks consecutively, so 21 days, and then she would have a 7-day break to have, technically it's not a period, but it would be a withdrawal bleed. And then after the 7 days has elapsed, the cycle would continue. So she'd take it for another 3 weeks, and so on and so on. But nowadays, we tend to prescribe what we call an extended regime, which is much better. So you would encourage what I do now with all my women, they take it for either 2 months back to back with no break, or in some cases, even 3 months back to back. and there's absolutely no harm in doing this. And then you'd have a 4-day break, not 7, where you'd have your withdrawal bleed. There's a new pill I think that's come out recently in America, where I think you even take the pill back to back for a year and then have a couple of days break. So things are definitely changing. But we know that not everybody can take the combined pill. So it's important for you to discuss with whoever's prescribing it. If you have a history of what we call a deep vein thrombosis or a clot that's formed in your leg or maybe in your lung, the pill would increase that risk. So we'd have to think about an alternative. So something without the estrogen component, so just progesterone only. You can have it if you're a smoker, but we'd advise if you are a smoker to consider stopping, because your risk again of those conditions are much higher. And I think if you're over 45 and a smoker, it's not the recommended pill to take. If you've just had a baby, we'd have to wait till 6 weeks before we can prescribe it. But there are other contraceptions like progesterone only, again, that are available. And if you've got some conditions like heart disease or high blood pressure, because sometimes the combined pill can increase your blood pressure. And if you've got migraines, but not just standard migraine, if you've got a migraine that comes with something we call aura, and aura are sort of, there are people with migraines who have warning signs that they're going to get a migraine, and that's the aura. And that warning sign can take the shape of, could be profuse vomiting, or it could be some visual disturbance where they see flashing lights. If that is the case, then we can't give you the combined pill. You would have to give you something else. And if you've got any active breast cancer or disease, we would again have to seek an alternative for you. But there are lots and lots of different choices, and actually you can take the combined pill up until the age of 50. So if you do fall into that category where there is a reason why you can't have the combined pill, you can have what we call the mini pill. I wish it wasn't called the mini pill, because sometimes people think, well, mini means it's not as effective. It is, it just is mini because it's only got the progesterone in it, but it works in exactly the same way. So it will stop the ovary from releasing an egg, it increases the thickness of the mucus, and it's very easy to take and effective. And the difference with this is there's no break. You just take this every day, although we know that some people can forget to take it. The challenge slightly with this, you need to take it usually every day around the same time, or at least within a 12-hour window. So, but there's lots and lots of different apps now I've seen women have on their phone to remind them to take it. So that's something that you can also consider. And one of the other main side effects I see in practice sometimes is irregular bleeding. If you are getting a lot of irregular bleeding on the mini pill after 3 months, always try and see if you can give something about 3 months. But if it's still happening, then see your GP or other healthcare provider to switch it to something else, because there's always a different form. There's so many different mini pills on the market now. You don't have to stick to that particular one. And again, if you have active breast cancer, you can't have the mini pill. So this brings me now to the intrauterine systems that we have. And there's so many now on the market, I sometimes struggle to keep up. Now, the thing I find quite interesting in practice, we all know someone who's had a horror story to tell about having a system fitted. But in practice, for every horror story you hear, there's 100 more that have had a really good experience with having an intrauterine system. The one on the left is what we call the copper intrauterine device. It's very, very effective. I think it lasts for up to 7 years, possibly longer. And it can also be used in emergency situations, which I think I might touch on a little bit at the end. So if you've forgotten to take your pill, or if the condom has split, then something like the copper device is quite useful. One of the drawbacks of it, however, is that it can, in some women, cause slightly heavier bleeding than normal, to the point where it just becomes unbearable. And if that's happening with you and there's nothing else that the GP can do to offer you something to ease that symptom, then you may want to consider an alternative method. The IUS, which is the second box, again, it's very small, fits in the palm of your hand, is the most common one we use is something called Mirena, but there's so many others on the market now. There's Kylena, there's lots of different ones, but Mirena still is the most popular one. And essentially, it's loaded with progesterone, and it releases a small amount into your system every day. And you can take it, it's in position rather, for up to 5 years, depending on whether you're using it on its own for contraception. But there are some women, and I think I touched on this a little bit at the end, that use it with HRT as well. So that's another system you can use. And there's newer ones on the market. The one on the fingertip is a copper one, little copper balls. I haven't seen it yet in practice yet, because we, in my practice, don't do this. It's called the ballerine or something like that. But again, it works in effectively the same way in terms of just making the womb more hostile, is the word they use, which is not a great word, but more hostile to having a sperm come along. Now, one of the things I've noticed a lot in practice is the fear component. You know, when people come to have not even just the coil, but even just coming for a smear, you know, no one jumps up in joy when it's time to have your smear done, or even just any kind of pelvic exam. And if you take anything away from the next 30 minutes, always remember that you are in control. It's really important that you were in control. Some of you might remember Margaret Munchetti, when she talked about her experience with having a coil fitted, and it was so traumatic for her, even when they took it out. And her screams literally made the whole waiting room was just in complete shock, because it was so painful. What I try to do with women is, there's a number of things. First, talk through what your expectations are, because the majority of people who have any devices fitted, it should not be painful at all, at all. It's always a good idea, before you have any sort of procedure, to have some paracetamol or ibuprofen, if you're allowed to, and take that at least an hour or a bit before you're going to have your coil fitted. I even know some practices, some GPs, who allow, I mean, I haven't seen it in our practice, who allow women to actually put the speculum is the device, the plastic device we use, into the vagina themselves just before the procedure started. And there's no harm in asking if that is something that you would be interested in doing, asking your GP if that's something that you could do. And there are a number of techniques we can use if it is painful, because everybody's different. As we get older, unfortunately, things, because of estrogen that we have in our system declines, it's not as much as before. Our ovaries only have so much capacity in terms of the eggs they release. So our estrogen goes down, and things down below in our vagina will tend to get drier. If they become too dry, it actually becomes not just painful to go and see your GP, even just having sex in some women can be very, very painful. So ask your healthcare provider if they provide any form of anesthesia around that area, because some GPs can offer some gel before they do the procedure, just to make sure that it's not as painful. And in extreme situations where it's really, really painful, it may be that you have your coil fitted in the hospital by a gynecologist if it's too unbearable for you to cope with. So no woman should ever, I feel, be subject to the pain for having a coil fitted at all. And I was really really happy when Margaret Munchetti brought this to the forefront, because not many women talk about this, and it's almost an expectation. Well, you know, if you've been through I don't know, childbirth, or if you've, you know, this is nothing. I've heard that been said to somebody, and that is just, I just literally have no words. That you can't say things like that. It's not acceptable. So coming on to another form, these are called your injectables. And the main one that we've got, again, these are progesterone only, is Depo-Provera on the left, and I've now gone completely blank, and I can't remember the one on the right. Okay, Cyanopress is the other one. So these are given in 14-week intervals, usually to the upper outer thigh, the one on the left. And they are very good because if it's given every sort of 3 months, again, you don't really have to think about taking anything. It's just there. In very, very young girls, so I'm going to say very young, under the age of 18, there was some concern a few years ago about bone density, and particularly, so it was young girls and it was older women. So again, it just depends on what is acceptable to the patient, because if bone density was an issue, you can always monitor that by using sort of bone density scans if they felt that that was acceptable. With depot, it does tend, however, to render a patient, the majority of them do not have a period. Some people are happy with not having a period, but, you know, some people prefer to have some form of bleed because that's their preference. So you'll find commonly that even when they stop having the depot, it may take a while for your periods to come back. And in terms of your fertility, that is another worry for some women, that once they stop the depot, again, I've seen it that, and sometimes it takes about 6 months, maybe a little bit longer for your normal cycle to happen. Cyanopress is the one on the right-hand side, is administered by yourself every 14 weeks, I think. And you do it just, I think it's your lower abdomen, and it's becoming really, really more popular now because, again, you don't have to rely on getting an appointment to see someone, you just do it yourself. So this is another one that's just come onto the market in the last few years. So a little bit about emergency contraception. My takeaway from this is, it's Saturday today, and last week I saw a young girl on the Monday, and I mean, she was fortunately just within the window, because emergency contraception is most effective when someone presents within the first 5 days. And her condom split on the Saturday morning, and I said to her, why didn't you do something Saturday morning? And she said, oh, I was waiting for you to open on the Monday. And I was like, no, it's now available over the counter. So that's something that you need to consider if anything happens at any point in your cycle, because some women think, well, even if I'm on my period, I can't get pregnant. You can. And I really need to stress that point. You can get pregnant at any point in your cycle. So if something's happened, say you've missed some pills, or the condom splits, or you've just had unprotected sex, then, and you want emergency contraception, there is always somewhere to go to at any given day in the week. The most common one is the copper coil. But again, I appreciate that how many people can ring their GP and say, I need to see someone now to get a copper coil fitted. That would hardly ever happen. But I know now that in some sexual health clinics, if you need to know where your local sexual health clinic is, that should be a service that is offered to you. If not, then we can prescribe 2 main forms of medication that's taken orally, or your pharmacist can make it available over the counter. You will need to do a pregnancy test after 3 weeks, especially if you don't see your period, because your period can come slightly earlier or it can come slightly later. So it's really important to do that pregnancy test. And if you're not on any regular contraception, you know, I had a lovely patient the other day. I was like, after the 3rd prescription, I was like, should we just think about some regular contraception for you? You know, what are your thoughts about this? So consider what your future options are, because we know that even though teenage pregnancy rates are falling, I think in England and the UK, we still have the highest teenage pregnancy rates in Europe, easily. And when you look at it based on ethnicity, we also have, as Black African and Black Caribbean populations, we tend to have the highest number of unwanted pregnancies and repeat abortions as well. And that's something that that's multifaceted. There's lots of research going into this at the moment. And some of it could be, this is my speculation, is maybe because we don't talk enough about it. I was discussing with a friend who might be on this call this morning that when I was even young and having a period, like I had to speak to an auntie And I was like, well, why can't my mum speak to me about my period? I don't understand what's going on. And sometimes we carry these behaviors unconsciously with us. When my daughter was about 5 or 6, there was that question that you dread, like, Mummy, where do babies come from? And the car was silent. And I remember thinking, oh my gosh, I should have thought of a story to tell her, like, you know, the swan or something that comes and delivers it at night. And my husband calmly said, well, men have an organ called penises and women have vaginas. And he went in, and he's a gynecologist, by the way, so I should have stated that. And I was looking at him horrified, and sort of saying, well, what are you doing? And he was like, well, I'm not going to fluff this. That's how it happens. And she accepted it. She was like, oh, right, that's very interesting. And I was shrinking in my chair. But that's, I think, because culturally and traditionally, we never spoke about things like that when I was growing up. And we now know, there was a big study done in Bristol University a few years ago, which looked at sex education in schools, because from 2020, it's become mandatory that relationship and sex education must be taught in schools. And it was found that children who were more informed were less likely to engage in risky sexual behaviours. So that's probably, you know, and that made me think, and that's as a healthcare professional, think about how we discuss sex, because it's not something we often do. And again, I remember, and I'm digressing a little bit now here, even with my own family, when they have issues, they'll say something, but it's so coded. And I'll be like, oh, do you mean you've got vaginal discharge? And be like, oh, you know, you can't say that. And I was telling a funny story, which I'll share if that's okay, Ngozi. There was, when I got married, you know, in some households, you know, we do come from some pressured households where, you know, it's all about education, then it's all about finding the right husband sometimes. And then when you find the right husband, I remember my mum, a year after I got married, she said to us, it was in a crowded room, oh, it's 1 year, 1 year. So I said, oh, 1 year since what? Since you've been married? And I was like, yes, happy anniversary to me, because I didn't understand where she was coming from, but I think everyone else in the room knew what she was getting at. And she said, oh, so what's happening? And I said, well, what do you mean what's happening? She said, well, I'm not saying anything. So that's how my mum talks. And I said, oh. And my husband calmly said to her, my mother-in-law, we are trying. We are having sexual intercourse every single day, but we just hope that one day it will happen. We'll keep praying. And I just remember thinking, I want the ground to open up and swallow me right now. But actually, she understood. She didn't ask again. So that was a really useful time to not talk about it. So coming on to HRT, one of the important things, I have women who come for HRT, but they actually think it has some contraceptive benefit as well. Contraception is not the same as HRT. So it's really important that if you have combined hormonal contraception, so the combined pill that I talked about earlier, that can be used as HRT up until the age of 50, but HRT on its own cannot be used as contraception. So that's something that you really, really need to be mindful of, particularly if you are like me in your later years of life and getting much older. Okay. What I really want to do again is just address, if that's okay, some common myths with contraception. Just quickly check the time, sorry, so I'll be mindful. One of the main myths is weight gain. Now, there is no published evidence that contraception causes weight gain. However, with the depot injection, we do know that it can increase appetite in some women, that they reckon that some women on the depot can gain on average 1 to 2 pounds a year. But anecdotally, in practice, depot seems, for me, it just feels like, I've been practicing for almost 18 years now, that it in a lot of my women, I've seen them gain far more than that in the year. And when they've stopped it, it has slightly reversed that. But that's how I've viewed it. The other thing is, the common myth is that it can cause cancer. In fact, it's quite protective. In fact, you find that's the combined pill, there's a reduced risk of things like ovarian or endometrial cancer. So that's the other myth. The male pill, someone said, well, I don't need a pill because there's a male pill. There's no such thing as a male pill at all. So that's something that I need to dispel as well. And some people worry that, well, if I get the coil, it will just fall out, or it will get lost, or the patch will fall off. I mean, I have had the odd story, and odd, where a couple, the patch for some reason used to get stuck to the husband, which I just couldn't understand, but it's happened. But generally, they are very sticky and they don't fall off. IUDs, generally, there's a string which you can identify. And don't get me wrong, there is the rare case where the string will just either you can't see it or you can't find it. And we do need to send a woman for a scan, which often just identify that the coil is in the right place. Some women, I've also heard that, well, if I go for a wee after having sex, that'll be fine. That's enough not to get me pregnant. That's not the case. So that's just rubbish, for want of a better word. So I can't find a better word. And then again, I think I've touched on women who think that having sex during their period will prevent pregnancy, and that's not the case either. Sterilizations, again, it's a complicated issue. Well, not complicated. It's not complicated. I don't know why I said that, but it's a form of contraception. It's technically, it's not recommended if you're under the age of 30, for obvious reasons, because people change their minds. And that's really important. If you are considering sterilization, you have to consider it as something that cannot be reversed. So once you make that decision, although some people do go for reversals, the NHS will not fund a reversal of a sterilization. That's really, really important to consider. Essentially, in the woman, the clips are applied to your fallopian tubes that I described earlier, and so they could block the tube. If the tube is blocked, the egg just can't travel down the tube. So that's what it means. And in the men, the sperm ducts, again, can be done under local. Some GPs do it, and that's in the form of a vasectomy. Now, I've seen it in practice a lot when you have a couple who've decided they've had enough children and they want to have a sterilization. And again, I'm speaking anecdotally, I don't have the published evidence, but it generally tends to feel that when you have white British populations, they seem far more amenable to the man having a vasectomy, because it's done under local. There's no general anesthetic that is required, because as women you have to go under a general anesthetic. It's a bigger operation, and I'm not judging, but it is something for us to consider, whether there is some cultural taboo with black men having vasectomies. I don't know, but I think we need to have a sort of conversation as to why there is that disparity. Sexual health clinics, I'm just quickly going to talk about this. They're all there, they are available, they do a lot more than we do, particularly when we're talking about things like sexually transmitted diseases. What we can't do as GPs, if I see a woman who, if I've done some swabs and the swab comes back positive for something like chlamydia, I can't do what we call the contact tracing, because they need to find out, right, who are the contacts that this particular individual has had, for us to find them and notify them. So that's why it's really important to do these things through sexual health clinics. But I know, again, like GP surgeries, like dentists, feels like the whole of the NHS, things are really difficult in terms of access. But there are some innovative projects. So where I work in Hull, we've got a mobile sexual health clinic that goes around, and that's really proven to be really, really good. In Liverpool, I know they have a project which is underway, which means that every man or woman is within 15 minutes walking distance of a sexual health clinic. So there's lots of things that are going on in the community at the moment. So I'm quickly going to touch on vaginal discharge in the last 5 minutes. Just want to say, discharge is normal. That is really, really important. Discharge is normal. I was out shopping recently with a friend, and she picked up something called FemFresh. And I'm like, what's that? She goes, oh, it's FemFresh. And I was like, FemFresh? She's trying to explain this thing to me. I was like, listen, that's just going to alter your the way your physiology is down there, because I see so many women that come with the most common cause is not sexually transmitted, is something called bacteria vaginosis. And often it's because they're using a plethora of different FemFresh soaps and nice smelling products down below. And it just water is sufficient. Because what tends to happen is when you alter the pH of the conditions in your vagina, other bacteria will overgrow and it can smell sort of fishy. Now, one of the treatments is no treatment, because you can just stop doing, you know, you can stop the trigger. So that is an option. But if it does get really bad, there is a course of antibiotics that we can prescribe for women in practice. There is something called trichomonas as well, and this is a sexually transmitted disease. Again, another myth is someone said, well, I think I caught this by using the hot tub. And I said to him, no, you caught it because you had sex in the hot tub. That's why you caught it. So it's really important to consider trichomonas as another sexually transmitted disease. Thrush is not sexually transmitted. I've put the bird there. I'm trying to think why I put the bird. Okay, because it was actually named after the bird. It's a long story. But the organism is called Candida, and the symptoms vary. You can get an itch, it can be sore, some people get some white discharge. Sometimes it could be a sign that something else is going on. So if you're getting recurrent episodes of thrush, because 3/4 of us will get this in our lifetime, not once, but more than once, but just consider underlying things like whether you have diabetes or iron deficiency as well. And it's easily treated with a single tablet or sometimes a pessary. There are creams you can get over the counter if it doesn't work, because sometimes the creams can cause more irritation than anything. And things like topical honey, my mum told me about yogurt the other day. I was like, no, and oral garlic. Again, these are just all myths. And then pelvic inflammatory diseases, because of course, all these infections that are sexually transmitted, like the chlamydia, for example, if they are left untreated, it can lead to things like ectopic pregnancies, where you have a pregnancy that's outside the womb, or infertility. And the thing is as well, some patients can have no symptoms. So it's really, really important that we try and find these disorders when they do happen. And there's lots of ways we can do that, through a urine test, bloods. My patients now even swab themselves. So if if people can't get an appointment, because that is a real big problem, I've been known to say, like, okay, what are you worried about? Okay, come pick up the swab. Well, there's a small leaflet to tell them how to swab it, and then they hand the swab in themselves. And then, that doesn't require an appointment. So that's another thing we could do. I'm conscious that I'm whizzing, and I'm really sorry. We should have done a part 2, Ngozi. Maybe we need to. That's my slight hint. Sexual problems. So painful sex affects at least 7.5% of us. And it's really, really distressing. And it's difficult, because a lot of women feel embarrassed or, going to speak to a healthcare professional about this. And there is so much that we can do to help. And it's really, really important that if you have any prolonged pain on sex, that's not normal. And there's things that we can do. Is it painful when there's superficial penetration or deeper penetration? Because there's reasons for both. Let me just come back to that. So if it's superficial, it could be a whole range of different things. Is there an infection? Is it because things are too dry down below, like we discussed earlier? There's a condition called vaginismus, which is, for some reason, which nobody knows why this happens, but you just go into spasm around your vagina area. And that can just be when you're being examined, or when you're going for a smear, or when you're having sex. And it's a really distressing and uncomfortable thing to have. If you've had a baby in the past and you needed what we call an episiotomy, where they've had to widen your birth canal, some people have some pain from the scar. So it's really important that you try and present, because we do need to know. And then if some women have it on deeper penetration, and again, there's lots of reasons as to why that could be happening, which I've mentioned there. And again, with our population, fibroids is something that people don't often tend to think about either. So the treatment for all of this, again, depends on what's causing it. I always say lubrication is a really good thing, because that does help alleviate some of the symptoms. And when we direct people to pharmacies, I wouldn't want to, in front of the Tesco pharmacy to announce what's wrong with me, but I suggest to patients, just write it down. Most pharmacists now also have a side room. Just tell them, look, I have a sensitive condition. I'd rather speak to you in the side room. There's ways that you can approach your healthcare professional to talk about this. If you find that you're not getting anywhere with the GP because they can't get to the root of it, ask them, can you just send some advice and guidance to a gynecologist to see what else it could be, if there's anything else that we could do. Some of these things could be psychological as well, and which will have a real impact on how we feel. So it's really important to also consider that as well. So I'm so conscious I whizzed right through that, but it's really just kind of a whistle-stop tour. One of the big areas I haven't covered, which I'm conscious of, is HIV, because I think that probably needs some remit on its own. I am wary that at least there are about 5,000 cases every year that go undiagnosed. So I would encourage, if anybody, again, there's a lot of stigma, social stigma around HIV diagnosis, but we know now that whilst we still don't have a cure, people are living much, much, much longer because of the treatments that we have in practice to deal with it. But perhaps I could cover that maybe another day. So thank you very much for having me.
Thank you, Margaret. That was amazing. And I like your word cloud with Asante. These are difficult to say thank you. How come that's the biggest?
Asante Sana. I don't know why that's the biggest. I just found it on the PowerPoint thing. I thought, well, they've made it the biggest. So yeah, Swahili, why not?
I think I will take your suggestion, because this was contraception and sexual health. And I think I'll take your suggestion about having a separate session for sexual health and to cover HIV. But that was amazing. And what I find is, even though I'm a doctor, I'm a pediatrician, I find all our health hours useful. And I always pick up lots of tips and lots of things I can discuss with relatives, things myself. It was a really good health hour.
Thank you.
So we've got some questions, and I've said, so my name is, you can tell from the screen, it's Dr. Ngozi Ediosage. If you are slightly embarrassed, you want to put the questions just to me, and I can ask them on your behalf, please feel free to do so. So we've got some questions. So one of them is the question about using the pill, the combined pill, and the fact that she's also got migraine and hypertension. So she said because she's on medication for migraine and hypertension, that she could take the combined pill. And I think she's just asking for some reassurance that that's the right thing to do.
Yes, so thank you. And I'm conscious Onyi is here. Onyi's my partner in crime. So thank you, Onyi.
Hi, Onyi.
So I think if your hypertension is well controlled on amlodipine, and your migraines are controlled with sumatriptan, and you don't have any of the condition aura that I was describing, so any eye problems when you have migraines, then it's absolutely fine to be on the combined pill. So that's really, really important. However, if it depends on how old you are. So like Oni says, if you are really over the age of 35, 40, I would consider using either the mini pill or something that was non-hormonal if you are, and I would encourage you to go back to your GP and ask for an alternative.
Okay. The person who asked said that they're 44.
Yeah. I would. I just think depending on your blood, I don't know. There's something that we use called risk scoring. It's called UK MEC criteria to determine whether someone should be on the pill or not. So, and I don't know, Anya, if you're there, but I don't know what the UK MEC would be if you're 44 with hypertension and history of migraine. Combined pill for me just feels a bit. Maybe she can't unmute herself because she's
Anyway, I'll go to some other questions while we're getting some solidarity from Onyi.
So, no, Onyi's just put, do not use that, please. She's just put no. Yeah.
Thank you, Onyi.
Sorry, I've managed to unmute myself.
Okay,
honestly, I think once you have more than one risk factor, so you're over 35 and you've got migraine, I think with the two of them is a complete contraindication. I would suggest you go back to your GP and have an honest conversation, because like Margaret said, something that is non-hormonal, like the copper IUD will be ideal for you, because then you don't have any hormones in your system. That will last you at least, most of it is about 10 years. So you don't have to worry about contraception again. Once you have it fitted, it can then stay in until you go through the change and you stop your periods and all that. So I would recommend you think about that as an alternative. But to have migraine and be over 35 and be given the combined pill, no. No.
Thank you.
Ollie.
Someone's sent a message that they've had bilateral tubal surgery, but still have really excruciating cramps during their periods. And should they be concerned? They haven't stated the reason why they had tubal surgery. I guess it doesn't really matter.
Okay, so yeah, so if they still so having all the bilateral tubal surgery I'm assuming if that's a sterilization, I don't know. It's just literally tie off your tubes. It doesn't address the problem of having painful periods. So if your periods aren't so what we do for painful periods, for cramps, we could use again the pill to control the cycle, because we know that reduces the amount of pain. You could be offered pain relief in terms of just anti-inflammatory tablet like, ibuprofen or paracetamol. But then if none of those things are working, I think you definitely need to go back and work out, well, why is it that they're really painful? Do you need a scan perhaps of your wound to just make sure that nothing has been missed and there's no other underlying reason as to why it's painful? So I would really recommend that.
Thank you. There's another question here that someone said that they keep getting recurrent thrush and they wonder, they've had lots of treatments, but they wonder whether their partner needs to have treatment as well. Because although you said it's common, they keep thinking, well, if I keep getting it, is it something to do with him?
It's not sexually transmitted. So this is a question that does come up time and time again. However, in practice, I do see this a lot where the other half also has thrush. And I'm going to be honest with you, once we've treated both parties, it does get better. So if your partner has untreated symptoms, it makes sense to just have them treated as well. If you keep getting recurrent symptoms, that's really, really important. Make sure you've been screened for things like iron deficiency, you're not diabetic as well. That's really, really important, just to make sure there's a reason why you're not getting this time and time again, because that's not normal.
So what are the symptoms in men? Because if there are any men here,
so
say it's nothing to do with me. So.
Yeah, no, it's a good question. Good question. Sometimes you get sort of similar symptoms. So an itch or a rash or soreness around the glands of the penis. So that, any one of those three or all of those three in some cases.
Another question that I'm hypertensive. I've had 4 children. Lots of things don't work for me. My husband's really against being sterilized. He's Nigerian. I feel your pain. Any reassurance for the men on the call about male sterilization? Because I think what she's getting at is she's got lots of risk factors for just having additional surgery, but she doesn't want any more children. It would be just if he got sterilized, isn't it?
It'd be so, So I understand there's a fear of having, I don't know whether it maybe needs a deeper, bigger discussion with lots of men around. What is the fear? You've got 4 children. Your wife is having to rely on, medication to control her blood pressure and so forth, and struggling with her fertility. I just think that we know this can be done under a local anesthetic. It's so much easier for the man, I'm just saying, to get sorted and get seen to. Why it doesn't make a man less of a man if you have a vasectomy. You can still perform your marital duties as you see fit. And I think maybe that's part of the anxiety, because they worry they won't have an erection, they won't enjoy sex in the same way. No, not at all. You'll still be able to function normally as you did before. It just means that you're choosing a more effective way of helping your partner achieve what they want to do. It's a relationship. You have 4 children. I can see Lamin and Oni just with hands up. I'm sure they want to maybe come in on this point as well.
Go ahead, Lamin. Tim, can you help them to unmute? Yeah, I think you're muted. Onyi, do you want to? I don't think Lamin can join us.
Okay, can I say something about the thrush? That was why I wanted to come in. So if
Okay.
you're having recurrent thrush, in addition to checking that you don't have other problems causing it, sometimes we tend to treat thrush for 6 months because we know that some women, for some reason, tend to have thrush that is almost hormonal, that is related to their, so every time they're
Okay.
about to have their periods or during their periods or after, they tend to have thrush. So what we recommend sometimes is that they treat for 6 months. So they will give them medication for like 72 hours. So the first 72 hours, they might take either a tablet or a vaginal pessary, and then they go on to then have a pessary or a tablet once a week for about 6 months. So I would suggest, if you're somebody that is having it, maybe have a conversation with your GP to see if they could consider you having that treatment for about 6 months.
Okay, that's really, thank you, Anya, because what I tend to do now as well is I actually refer to the sexual health clinic for recurrent bad episodes, because most times there was a bug I put there called Candida albicans that is the main cause, but there are other types of Candida that can cause recurrent thrush, which we can't test for in primary care. So again, that's really useful to know that there is prolonged treatment, but I would also encourage, contacting your sexual health clinic to get swabbed there, because they can access the lab in a way that we can't most times out of 10, and ask for what we call typing. So they type the type of Candida just to make sure that nothing's been missed. Does that? Yeah, thank you for that point.
There's another question here that I'm in my 70s. I've met somebody recently. I want to have a sexual health check. Would they do that for people in their 70s?
So if a woman in their 70s came to me, I would just say thank you for coming, because often people think, you get to a certain age and sex is not for you. I would hope that I'm still sexually active at 90. I know my husband probably thinks, oh my God, what do you mean? But, why am I stopping? So absolutely, book in to see your GP and just discuss if you've got any issues, any concerns, any anxieties. Please do. Absolutely.
Thank you. I think that was and thanks for the question. There's someone who's asked about why does the contraception pill, why does it increase high blood pressure and weight gain?
I know, I was looking at that question. So I'll come to the weight gain first. There's no published evidence it causes weight gain. So that's just it's a myth. Although there is some speculation that it increases appetite. Well, if it increases appetites, you're hungrier, so that by default you're going to gain weight, but it doesn't cause weight gain. But the hypertension bit is the bit I'm trying to get my head around. I suspect probably due to the hormonal effect on the blood vessels. That's the only thing I can think of with my pathophysiological brain on. And that I think if you are already predisposed to having high blood pressure, that it would just enhance that effect. So if you have uncontrolled blood pressure that's not managed by conventional treatment, that's why it's a risk that we just couldn't have the combined pill, because it would increase it in that way.
Okay, that's really helpful. I can't see any more questions actually.
No.
Come forward with any more questions. But that was a really, really, really good session.
Okay, there's something on fibroids. Sorry, do fibroids cause? I know, but Oni's responded. Sorry, okay. Cause conception problems. Yeah. So, so with regards to fibroids, we do know that some women who have, it depends again on the size and the number. So potentially, if you have really bad fibroids, it can actually cause difficulties in getting pregnant. We do know that. And if that happens, then you would need to seek advice and possibly treatments from your gynecologist, because we know now that the removal of fibroids, what we call myomectomies, are on the rise now. I've got lots and lots of friends in their mid-40s who weren't able to conceive and who are now trying to address it. In fact, I've got one who's actually fallen pregnant since she's had her surgery. So if you find that you're trying and you haven't been able to get pregnant and you know you've got fibroids, I would seek advice from your local gynecologist if you can.
Yeah, that's really, really good point. definitely. And I think we'll have some more sessions on fertility, because it's always an area that we just need to just clear on for people, and so people know their options.
Yes, yeah.
And I think we do need a separate session, because this was a really good session for all the things to do with contraception.
Yes, and then I got to the sexual problems bit, and I thought I was rushing a little bit.
No,
and that's a bit that I think would be really, really useful to have especially around addressing taboos in terms of how we approach different treatments. Yeah,
different treatments, discussions at either ends of your reproductive career and your life, because I think there's a lot of misunderstandings with the very young, and then you get to the older age and there's misunderstandings about what happens at the end. Because I remember when my daughters were going to have sexual health lessons in class, and we talked about some things, but it was very graphic, and they were going to teach them how to put a condom on, and they were 14. And I just thought it was a bit much. But then I found out that in a neighboring school, there was a 14-year-old that was pregnant. Yeah. So it did make me rethink about a 14-year-old's old enough to understand what happens. So for some of them who are engaging, it's better to try and prevent early pregnancies, because as you pointed out, it's much more in the UK.
Yeah, and I think so, Ngozi. I grew up in South London. I remember back then, the year above, before we left secondary school, this was a convent, just as well, but 90% of them had a baby year after leaving school, and these were 16-year-olds. And I remember saying to my cohort, if there's one thing you do when you leave, at least live. Think about uni, think about something else, not just having a baby. And there's nothing wrong with having a baby young, but you want to be in a better place to be able to support having a family. And I just felt at 15 or 16, you're just not going to have that level of support, really. It's mind-blowing. And if it's not coming from us, they're just going to learn it from somewhere else.
Yeah.
And they'll just pick up misinformation if we're not there to steer them and guide them. Because I can't keep track of the way social media is and the way they engage with it now. It's just a minefield. So, whenever like my son went on holiday, so I'm digressing, after his A-levels, they went to, it's like Zante. And my husband went and bought him some condoms. And I was like, what are you doing? Because we're Christian. I'm like, it's like you can't tell him not to have sex before getting married, Margaret. What planet are you on? Because he's clearly the very real parent. And I just had to accept it that, it's just one of those things. I'd rather he be protected and free from infection and not impregnate someone at the age of 17. But yeah, I think we need a whole sort of bolder discussion around it. Yeah,
we do, but I think this is the real world that they live in. And if you have the attitude where you think that they're not going to do anything, and all you say is don't do anything, they won't come and tell you. You can't engage with them and buy them the condoms. And if anyone's on this call and excludes their children from the sexual health lessons in class because you feel it's too graphic or too detailed, what they do is that they just ask their friends. Yeah. So my girls that are there, they'll say to me that the girls who weren't allowed to sit in class when we had those lessons, they've come to ask us what we were told. So they're getting it second and third hand from people who have little understanding, who they put their own interpretation on what they've said. So please, if you do have children who are having these lessons, you can ask what the framework will be, and you be the parent who understands what's being told, so you can interpret it for your children when they come home and asking additional follow-up questions. But don't exclude them, would be my advice.
Yeah, there's a really good website which I'll share at the close that parents can go to actually, just information if they're not sure or just want to have a look to see how to speak to their children. I'll put it in the chat if that's okay. It's the Family Planning Association, where they do a lot of around health and sex education. Really, really useful.
Okay, so thank you so much for coming once again. I think we will definitely have you back again. We'll have a double act for yourself and Onyi.
Onyi, yes. Oh, I warn you,
good,
the chaos. We do our little duo. We've gone around the country, but yeah, it'd be good if you could. It would be good.
Thank you, Onyi. And so what I would employ you to do is just, we have a poll that we'll put in the chat, so you can respond to say how you found the session, and also suggest new topics, because all these topics are for you, and for you to be empowered and to take some kind of ownership and control for your own health as well, with a bit more knowledge and understanding. So Margaret and Onyi, thank you so much for coming. I'm going to hand over to the CAN team to tell you what's happening this week. But
Thank you.
Hello, good afternoon. Just before my colleague Michelle comes in to let us know about the next events and services that we have for CAN, everything that's happening with CAN, I just wanted to quickly apologize for any disturbance, anything that might have happened, that happened in the chat. If anyone noticed, we wanted to apologize if anyone got offended or in any way, caused any inconvenience. Do reach out if you want to give us some feedback. We are more than open to. And again, just to apologize. Unfortunately, this is a public session, so sometimes we will be disrupted and interrupted. But again, let's continue the good work that we do. Thank you so much. I'll pass on, Michelle.
Thank you, Natasha. I'm just going to share my screen now. So first of all, I'd like to thank Dr. Margaret for such a fantastic, informed session on a very important topic of contraception. It was absolutely brilliant. So thank you, Dr. Margaret. And I'd also like to thank our host, the wonderful Dr. Ngozi. It was absolutely brilliant hosting today. And I really enjoyed your beautiful fish tank in the background also. And I'd like to also thank Dr. Onyi, who was also supporting with our attendees' questions today. Thank you so much, Dr. Onyi. So I'm going to start the slideshow now. So sorry. Sorry, 1 second. I'm so sorry. I don't know why my slides are going. So thank you, for joining us, all our attendees, for this week's Health Hour. And they take place every Saturday, 11 till 12. Sorry, I hope I'm not freezing there. And next week, I'd also like to thank all our attendees for joining us today. We had a great attendance, and so thank you for taking your time out to join us. Next week, we have a wonderful topic delivered by Dr. Joe, and that's going to be all about headaches. So please join us again next week. Here at CAN, we also have many fantastic services that we're offering, and every Tuesday we have our Healthy Hearts, which again is delivered online. Please get in touch with Health at CAN if you'd like to join us. It's hosted by our wonderful Dr. Hibber, and next week we've got our guest speaker, Dr. Wise, who's also a dietitian, and they'll be talking all about arthritis and diet. So please join us there. And we also have our physical instructor, Orlando, who does the last half hour of the session with an amazing workout. Our family and advocacy support sessions, they happen every Wednesday. And next Wednesday, the 9th of August, we're discussing a very culturally appropriate topic around assessments and getting the right support. So we've got Nellie Azenwi, who is the social worker, who will be speaking all about that. So please do join us if you're free. That's Wednesday, the 9th of August. It's in the evening at 6 o'clock. And these family and advocacy support sessions take place twice a month. So it's every second Wednesday. and they're all different topics each week. So please do come along to those. We have our wonderful health and wellbeing choir. It happens every Thursday in person. Everybody meets up, and you get to just express yourself through singing, or indeed, if you do play an instrument, bring that along. It's a lovely group who meet together in a lovely setting, and the magic happens. So that takes place every Thursday, 7 till 8:30. You do register through our portal, and the details are on the flyer there. And our choir lead is a lovely lady called Elva. So get in touch if you're interested. All the details are on the screen. And this is another very important topic. We really do need more people from our communities, from the African and Caribbean community, to give blood. And I signed up last week, and basically it is saving lives. So please do get in touch with us. We can direct you through how to get involved and how to register. Many of our staff are already also joining this very good cause, because as I said earlier, not enough of people from our backgrounds are donating blood, and it does save lives. So please do get in touch with us if you'd like to know more. And are you interested in being a part of equality and a race equality panel? Are you passionate about tackling racial inequality? We're looking for people. Carney's working in partnership with Greater Manchester Combined Authority, and we're looking for people to join that panel. And it'd be great to have more of us from our communities, giving your voice to this, again, very important topic. So please do get in touch with us, or even you can visit the website as well. We have a page which is all about the Race Equality Panel and what it involves. And indeed, you can also make an application to be a part of the panel. So please do take a look at that. And yes, this year has flown really fast already. It's next month, to be fair, 28th of September, one of our wonderful flagship events is happening in Black History Month at the Manchester Cathedral. Please do save that date in your diary, the 28th of September, and get in touch. We'd love to see all of you there celebrating this wonderful month of Black history. And last but not least, we'd like to thank our amazing partners who support us in making this health hour happen each week. And that is the RAFA, the International Development Agency. Sorry, my screen's just in the way of, it's Croydon BME Forum, it's the Enfield Caribbean Association, BHI, which is the Black Health Initiative, and of course the Redeemed Christian Church of God. So we'd just like to once again thank our partners and each and every one of you for joining us this Saturday for our health hour. Thank you.
Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.